A lot of courses often just kind of show how we use a product for an occasional use. Tonight, I'm all about daily regimens. And what I can tell you is that these are the occurrences that happen on my patients in our practice. And this is just an example of a geriatric patient that I'll close on tonight in his case. And this is 2D AI presented by Pearl, just showing you different types of caries, how we're going to treat them, not just geriatrics, but also when we're dealing with moderate depth caries, which I'll show you a case tonight. And then we'll start to understand how safe is it to use SDF in deep caries. So there's a ton to share tonight. And I'm going to start with two statements. And as you read this statement, I think this is the core of what we tried to do is if a sealed active carious lesion could turn into an inactive lesion with enhanced dentin remineralization, regardless if some amounts of residual caries remain, is that not our goal? And you all know you leave decay. And it's okay to leave decay, but, and we'll get into that, but we all leave decay, or we do. If treating a deep asymptomatic carious lesion preserves the vitality of the tooth, is that also not our goal? And we're going to talk about that tonight. So this is far more than just SDF. So I'm going to say, of course, thank you to SDR for sponsoring this. I, of course, will show some of their products and others tonight. But thank you, SDI. And there'll be a message and an offer to everybody after the program for attending. So what is this solution? So silver diamine fluoride is composed of silver and fluoride as the active ingredients. And we're going to dive deep in those two active ingredients. And we also know it's applied directly to basically pathological tissue. And we never use local anesthetic. I want to be clear here, it is totally off-label to use this to arrest decay. Now, off-label doesn't mean you can't use it. That's what we're doing every day in our practices. But I just want to be clear, it's an off-label indication. But the key is, what it says is it promotes remineralization of carious lesions. So we're going to dive deep into this. I think it's a twofold effect. It's an antibacterial effect, and it's a remineralization effect. And it inhibits biofilms that can be strip mutant. But as you can see on the graph next to it, there are doctors who use SDF, for example, in Australia, New Zealand, and in Europe to do root canals. And that's why you'll see it works against E. facialis and other bacteria. So it is absolutely there to inhibit cariogenic biofilms. So on label, it's indicated for desensitization, period. That is the on-label indication. And SDF has been studied over the last 50 years. And if you Google it, it's just countless articles. And in this particular article, and I'm just going to highlight 331 studies, 3 were considered low bias. Only 1 application had between a 25 to 56% desensitization. That's just 1 application. The literature has found it to be more effective than potassium nitrate, potassium oxalate, and glutaraldehyde. So this is more effective. And obviously, if it's multiple applications, you'll have obviously decreased sensitivity. But it's been proven to be more than all of what I would say is the competitive materials. So when I look at the process itself, there's really 2 ways of looking at it. With the traditional, what I call silver diamine fluoride formulations. And really that came out with Advantage Arrest, great product, and Riva Star, the original Riva Star. And the indication was you had to isolate your gingival tissue because it's very alkaline. It can be very alkaline and burn the tissue. And these are ammonia based. And we'll talk about this also. Well, after you clean the area, the sensitive area, just with probably some non-fluoridated prophy paste, the instructions are you would just apply some SDF right into the area. You would allow it to basically saturate the area for 1 to 3 minutes. And I would tell you we would use it really as up to 3 minutes because we would want that deeper penetration. After we were complete after that 3 minutes, we would just gently blot dry the area. And that was it. Now, sometimes you could get a little blackening of the area. It could be demineralized tissue. And the literature says to use a tincture of iodine. Well, who's got iodine on hand? And you're going to see why I think the next generation of what I'm going to present to you is a game changer in SDF. Because the issue is black staining. So when you apply silver when you apply the SDF, basically the silver oxidizes and leaves that black stain. And it's a result of the formation of silver phosphate and silver sulfide. And you normally start to see it in about 2 minutes, and it becomes very visual in 5 minutes. And you could get really staining in irregular areas on the tooth. And the discoloration, and this is really important, it's more profound when you apply it. Let's say when you've just got a deep cavity and you don't take out any of the infected decay, the black staining will be even more apparent. So we'll talk about removing the infected dentin and then as subsequent to that, using SDF. So there are multiple ways of doing it, but a key point is the more infected dentin or the more infected the caries you remove, you'll see a little bit less black staining. The product that really has been our go-to, I don't know, for the last 2 years in our practice is Rivastar Aqua. And the key is it's a water-based SDF formulation, so there is no ammonia. And the part 2 of this is that it comes with a potassium iodide. Rivastar, the original, with ammonia did. Well, this is Rivastar Aqua, where part 1 has no ammonia, and part 2, which is the green bottle, is potassium iodide. And I'm going to explain to you about potassium iodide in just a few minutes. The reason I love this is you really don't need to isolate the tissue. I would still protect the lips and the gums, but you really don't have to worry about it. The pH of this is mildly acidic versus the traditional SDFs are very alkaline. No smell. And I would tell you the treatment time is substantially quicker, which I'm going to show you in the desensitization process. So if you follow the same first 3 steps and no rubber dams are required, you will apply 1 drop of Rivastar Aqua, just 1 drop, and then you immediately place step 2 with another drop of potassium iodide. And basically, you're just brushing over step 1. And the key is to keep applying potassium iodide. Usually it could be 15 or 20 seconds, maybe 30 max, until the solution is clear. And I'll show you, initially you have a little bit of a white opaquish appearance, and you just keep scrubbing, and I'll show you that, and it turns clear. Then you just blot dry. Obviously, you remove the cotton rolls. If you want to use Rivastar Aqua in the unidose, which is what I just prefer to do, but again, that's up to you. You basically puncture the silver capsule, and I usually tap it on a table before I puncture it. I'll puncture it with, usually there's accordingly the same kind of, there's a silver brush. So I'll puncture it, apply the Riva Aqua, then I puncture the green capsule and immediately start brushing on the same way until the solution is clear. So you're not waiting 1, 2, or 3 minutes. It's you basically rub the SDF, step 1, and then immediately go to step 2, which is the potassium iodide. And you don't have to worry about tissue and burns. That's why I think this was a huge improvement from early SDF formulas. Now, the potassium iodide, as you can see in this picture, and I'll show you this case in a few minutes, that's the opaque color. And what you have to understand is basically the potassium iodide precipitates out any of the free silver ions that have not really reacted with the tooth structure. And when they form with the tooth structure, you're looking basically at silver iodide. And this prevents the staining of the surrounding tooth and materials. What you need to also understand, it's a very highly antibacterial precipitate. So I'm going to show you a really interesting study about this. So you have antibacterials of the silver fluoride, and you have antibacterial properties of the potassium iodide. But you must scrub this until it becomes clear. If you do not restore this, I have found in my practice that you still will get some darkening. It's not like the blackness fully goes away. I do see some darkening still. So if you're only applying this step 1 and step 2, it won't be as black. You want to take more of the decay away, but you'll still see some darkening. But tonight, I really want to talk off-label, and I want to talk about caries management. And we're going to talk about how do we arrest caries, then we're going to talk about treatment for deep caries, and then I'll close tonight on our geriatric treatment and options. So this study, which was really, really interesting, really showed that SDF is the most effective material to prevent degradation of collagen and demineralization. So when you think about what we're doing, whether it's a one step, when I say a one procedure step, where you're just applying this to the tooth and that's it, or you're going to apply it before doing the restoration, this prevents that degradation of collagen and demin. And let's all understand that composites leak over time. So if we can build that barrier underneath our composites or underneath our composites and glass ionomers, this is just that extra protection, and most people don't understand that or realize that. So if you're treating children, and I want to be clear here, I don't treat children, but if you're treating children, you're going to want to reapply this every 6 months. And really, that's what the studies show. One application, then in 6 months, another application. And this is how we really inhibit caries growth. And I'm not slamming fluoride varnishes. In fact, I believe, obviously, in caries risk patients to get fluoride varnish, this is far more preventative on a lesion than fluoride varnish. Tonight, I'm not going to cover early treatment of E1 and E2, which are early enamel, deeper enamel, and early D1 or dentin lesions. I've used Icon in the past. I've used Silver Diamine Fluoride. I have used Carious, and Crystal Care is the latest to come into this field. So there are other ways to treat early caries beyond just SDF. And I will tell you, I do think for early caries to enhance remineralization, I think Carious and Crystal Care are going to be really home run products and with no staining. So I'm just bringing those up because I always want to educate you with what we're doing in our practice. That'll probably be a course, probably, I hope, in April or May, where I can share with you step 2 or part 2 of tonight's course. So let's get back to arresting caries. So this is Ellen. She's 78 years old, and she came in, did not want a crown, and number 40 was a breaking down amalgam, both on the buccal and there was an MO. And she just had temporary discomfort to cold, transient cold sensitivity, nothing irreversible. So I'm going to walk you through how I take out caries, how I treated Ellen as really one of our 2 clinical cases. After I've removed all the amalgam and whatever burr you want to use to remove the amalgam, I use this burr. This is called the Syrah burr from Comet. And it really only removes infected tooth decay. I can't get deeply into it, but this is how I do selective caries. It's recommended to be at 1,000 to 2,000 RPMs in use. So it's like rotary caries removal, slow speed, like rotary endo. And so on my SK electrics, I can dial down the speed to 1 to 2,000 RPMs. The burr it's a zirconia aluminum dioxide and stabilized by yttrium. It is a multi-use burr. You're just going to autoclave it, and they last ages, ages. They come in 8 sizes. This is the kit. And this is the autoclavable kit that we can use. I use this pretty much on all my decay removal procedures because I don't want to take away dentin. I just want to take away infected dentin. I don't want to take away any healthy dentin. And what you will see is you see these shavings. And so what happens is at this slow speed, you'll start to see the shavings come up. And then ultimately you see the shavings they stop. And that's when you stop. When you don't see shavings, you stop. Now that's if you're at a moderate depth where I want to take out all the infected dentin. If I'm deep, which I'll get to, I'll use this burr, but I'll be much more determined to use it only where I want to on the gingival or dentinal floor. So here's more evidence of the shavings before I rinse the tooth off. But now I believe, removed the majority of the infected dent. So the second or the third research article I'll show you tonight is when you use SDF, you increase the resistance to secondary caries, whether underneath a glass ionomer or a composite restoration. So think about this. All we normally would do is we remove the decay or the majority of it, then we selectively etch or total etch and bond. Some of you will use liners. I'm going to talk about that in a few minutes. This adds that extra resistance to demineralization. So before I place silver diamine fluoride, I follow the literature and I etch for 10 seconds. So here's a pause for everybody. I want you to look. I'm etching before I'm placing the SDF. I'm removing the smear layer, probably opening up some tubules to allow better SDF penetration. So after etching for 10 seconds, I'll rinse and lightly dry. And yes, I do see the crack. We'll talk about it. Asymptomatic to chewing. And I see these cracks all over the place. And I'm telling you, everybody wants to crown. I'm very conservative. This, so to speak, we'll call it craze line, could have been there for the last 20 years. So after I'm done rinsing and lightly air drying, you can either take 1 drop out of the Riva Star Aqua bottle. Again, shake it, tap it a couple times, and 1 drop, and just rub the area, or use the Unidose. Both are shown here. I'm just going to scrub the area, just very gently. The key is immediately to place the Riva Star Step 2, the potassium iodide. Now you're starting to see its precipitation, and you're just going to keep scrubbing for another 10, 15, or 20 seconds, and it will disappear. Now, this article showed that the penetration of SDF goes through the entire carious lesion and allows the antimicrobial effect to occur. So the silver now is penetrating through remaining caries, and I'm going to show you how deep this actually penetrates. But additionally, Riva Star Aqua has shown that on the hydroxyapatite, that it has an anti-biofilm effect. So you have now two things going on. You have the silver penetration, you have the potassium iodide or the iodide, and you have this anti-biofilm effect. And you think about this, this is the long term. So now how are we going to restore this? So we've etched the tooth for 10 seconds. We've then rinsed, blot dried, place step 1 and step 2. It's clear solution now. And now we're going to, in my practice, we're going to follow, in this case, placing a glass ionomer. You do not have to. In the next case, I'll show you other options. But these are the glass ionomers I use in my practice: SDI, GC America, and Voco. So I will just tell you, these are the glass ionomers. I do not use 3M's glass ionomers. I just don't work with 3M. Nothing wrong with them. I just can't comment on them. So Riva Self-Cure and Riva Self-Cure HV, I just want to explain this. Both the Self-Cure and the Light Cure, they have two viscosities. The regular has a little bit more flow. The high viscosity is more packable. You pick what you like. It's whether you want a little bit more flow or the high viscosity just allows you to pack it. You'll note the orange tip. This is on Riva Light Cure. This prevents premature setting. So if you're doing multiple restorations at one time, you would absolutely benefit from the material not setting up in the syringe tip because you've activated it and you have a certain amount of work time, which we'll get to. So after I've thoroughly rinsed and dried the area, I'm now going to triturate the Riva Self-Cure after I pushed down and activated it. So again, I've already SDF'd. Now I'm placing my Riva Self-Cure glass ionomer directly over the area that we've cleansed. I usually wait about 30 seconds. And I like to wait about 30 seconds because the material goes through a hardening process. This is the Self-Cure glass ionomer. So after about 30 seconds, I begin like taking my composite plugger and just packing it down. This is the initial shape I want to get to. So I just want to show you this. You have three options with Riva Self-Cure. The green tab on the bottom of it is its normal regular, a little bit more flowy. The Riva Self-Cure Fast Set gives you about 35 seconds less working time. But when you're doing a single restoration, I'm telling you, you don't need more than a minute. So I wait 30 seconds, I pack it down, and then I just stop. Riva Self-Cure high viscosity is a normal minute 40 working time, but it's just more packable. You know, openly, it's what you like. You like a packable, and if you like a little bit more flow, I just like the fast set because I don't need a minute 40. And you can see the fast set sets in 2 minutes and 30 seconds. And for me, I'm ready to go. So 2 minutes and 30 seconds is plenty. So at the 2 minute and 30 second or the 4 minute mark, after it's set, I'm just going to re-prep the floor of the excess glass ionomer. I'm going to remove any glass ionomer on the walls. And this is what you see. And I'm just going to go back one slide. You see that red burr, that red finishing burr, composite finishing burr. I take that on my occlusal line angles just to bevel my occlusal line angles briefly. There's a little extra left on the distal. We'll get rid of that. But you can see I've flattened my floor. Sorry. I want to have at least 2 millimeters of space for my final occlusal composite. This is not in the gingival box at all. So now I've got my glass ionomer, and now I'm going to do my final layering. Total etch. And then after a total etch, I'm going to rinse and lightly dry or blot dry the tooth. Whatever you want to do, but I'll lightly dry the tooth. And then I'm going to place my universal bonding agent throughout. So I'm going to scrub my universal bonding agent for the 20 seconds. That's what it says. And then once the bonding agent is on, I'm going to air dry for 5 seconds, a little heavier, and then, I'm sorry, a little lighter. And then I go a little heavier as I come a little closer. And you'll see there's an air-only syringe tip. I don't use air water for this. Water comes out of an air syringe tip. So I don't want any water in my hybrid layer. So I want to be clear here. I'm going to rinse first and then just basically use a surgical suction and then blot dry. I'm going to then scrub my universal bonding agent for 20 seconds throughout. I'm going to air only dry lightly at a little bit of a distance, then a little bit heavier, and then I'm going to light cure for at least 20 seconds, moving my light to incorporate all the line angles. And this is my Velo Grand, and it's just got a large curing tip, and I can absolutely know that in 20 seconds, both the depth and all the line angles I can get to. If it's really deep, I go 30 seconds. I don't want to under light cure. In this case, I use a bulk fill flowable, self-leveling. Surefill SDR flow is another option. Here I'm using Shofu's beautiful bulk fill flowable. And so what I'll do is I'll inject it on the floor, keeping the tip in the flowable, always keeping your tip in, inject slowly. Then take your tip out, let it self-level, and you're going to light cure again for 20 seconds. And in this case, we were actually using and loving SDI's hybrid composite called Luna 2. So I actually first then created my marginal ridge. And this is all with warmed composite. And then what I would do is I would add a little bit warm composite on the lingual cusps, then the buccal cusp, minimizing my C factor. So I like going cusp by cusp, shaping each cusp. I don't believe in tertiary staining. I just don't do that. And I light cure each cusp 5 seconds. So you have minimal C factor pulling. So one cusp at a time, lingual first or the buccal first, and then going the opposite side. After I remove my matrix, I like to still cure interproximally. And this is after completion. That's actually a 2-year follow-up. But 2 years later, she's now 80, totally asymptomatic. And of course, I save the images of the crack. Of course, I'm going to make notes on that. Of course, I'm going to tell the patient, I'll take an intraoral image, show the patient the crack, and say, this may be an issue, it may not be an issue. Now, if you think about it, I used SDF, obviously, to cleanse it, obviously remineralize it long-term, and then this was my approach to a glass ionomer, then etching and bonding and placing my final composite. And I wish this picture wasn't blurry, but you don't see that white, like little, I call it that little white marginal. And that's from basically enamel and the composite tearing, or really the enamel and the dentin splitting. So I just think when I do cusp by cusp, minimizing the cuspal pulling. And so let me just again say, to correct myself, that white craze line on your occlusal, that is a crack in the enamel. It's not between the composite and dentin. It is a crack in the enamel. And so, again, I don't think it comes from polishing. I think it truly comes from a lack of beveling and a lack of not understanding C factor. And that's why I love to go cusp by cusp. Deep caries, part 2. And I'll take all the questions afterwards. There's a lot here, I know. So here's a key point. You do not want to put SDF on a vital pulp. You don't want to touch it. You just don't want to be there. It will cause pulpal necrosis. Fluoride in itself is toxic to the pulp. So when you have a pulpal exposure, that is not the time to use silver diamine fluoride. So if you know that it's toxic to the pulp or it can create inflammation to the pulp, what is considered a safe distance when you're placing SDF in regards to RDT, which is the remaining dentin thickness? For those of you who don't know, remaining dentin thickness is the thickness of healthy dentin between the, I'll call it, caries affected dentin and the pulp. So what distance is that? And then the next question is, how far does the SDF actually penetrate into the affected dentin, and then into the arrested dentin, and then into the unaffected dentin? And I'm not sure many people know this. So I dived into the research to basically explain how we use this in our office. So if you look at dentin in a cross section, the red shows infected dentin. 2 in blue shows the next surface would be the affected dentin, and 3 in green would be the healthy dentin. And so the question is when you apply SDF onto the infected dentin, how deep does it permeate through? And that's what we're going to talk about. The third statement is that silver will penetrate through the necrotic infected dentin, which is the soft dentin, then into the affected dentin, which is usually the leathery dentin. Some of it may be stained dentin. And after the affected dentin, it can go beyond that into the unaffected dentin or the healthy dentin. So it penetrates through infected to the affected and can penetrate into the unaffected. And this is why the remaining dentin thickness is so important. So this is a graph that shows the fluoride ion, whether in Rivastar or Rivastar Aqua, actually continues to remineralize through the infected, through the affected to healthy. So all of this article just showed that the fluoride ion and the iodine ion penetrated through the infected to the affected to healthy dentin. So here's this wonderful remineralization process going on. And I think this is such a pearl to know when you're using SDF. So this graph, and I'm going to break it down, it shows the remaining dentin thickness in green. So in this case, there's 0.7 millimeters of remaining dentin thickness. The depth of the lesion was 2 millimeters, so you had 2 millimeters of caries. And the silver, as you can see here, the silver penetration went beyond the caries, the lesion depth, and is going to penetrate then into the remaining dentin thickness. In fact, it was consistent in this research. As you look at the others in numbers 2, 3, but they all, you will see the blue, which is the silver penetrating deeper through beyond the lesion into the remaining dentin thickness. So I think this is a key point. This is not just a topical application. It's permeating through all the infected dentin, the affected dentin, and kind of remineralizing the remaining healthy dentin. I'm going to show you the 0.2 millimeters because this study showed that if you have less than 0.2 millimeters or less of remaining dentin thickness, you will penetrate into the pulp. So 0.2 is really too close. So if you know that you have 0.2 millimeters, I'm not even going to recommend silver diamine fluoride. So I want you to have at least a 0.5 millimeter of remaining dentin thickness. And we're going to talk more on this, but this is a key point. I'll show you what to use or what I use, but I just want to show you this is a key point. So that barrier of 0.2 millimeters, 0.3, 0.4, that's that iffy area, 0.5 and above, we're okay. So let's talk about remaining dentin thickness in general. So there have been countless studies over the last 35, 40 years. Pomeraniec showed that you needed more than 1 millimeter to protect the pulpal tissue from really the cytotoxic effects of certain restorative materials like zinc phosphate. That was greater than 1. Stanley said you need 2 millimeters to avoid injury. Now realize when you're putting even a composite on the floor, that could be inflammatory to the pulp or fluoride in a glass ionomer could be inflammatory. Murray found that it was over a half a millimeter, and Fuchs found that under 0.25 millimeter, if you had 0.25 millimeter of remaining dentin thickness, no matter what you did, you were gonna have inflammation. So how do you make, I don't know, how do you make this work for all of us in a decision making every day? So the case I picked was Michelle. I saw Michelle a number of years ago. She was 25 years old. Her uncle was her dentist. She had gone to him every 6 months, had no restorations in her mouth. Number 30 was negative. Tooth number 30 was negative to an Explorer, no stick. But I could see a little brown halo. I'll show you that. So I saw the brown halo, and you get to a point where your eyes tell you more than an Explorer. I was using Logicon at the time, and that's where you see these green and blue lines, and that would tell me if there were class 2 caries, and there weren't. Their caries on the x-ray was outlined as I looked at it with the red line. But the key was my diagonal, which I absolutely believe in, is so much better for caries detection using its fluorescence technology, read a 68. So I knew there was a cavity. You can also see on this x-ray the distal pulpal horn had receded. So this cavity had been there a while. So this is how I look at it. There's your caries. I'm going to assume there's some affected dentin. And below the affected dentin is your remaining dentin thickness. And this was definitely greater than 0.5 millimeters, probably closer to 2. The depth of the penetration of those silver ions going into the remaining dentin beyond the affected dentin is really determined by, is the dentin sclerotic or are the dentinal tubules wide open? So in a young person, normally the dentinal tubules are wide open and they're large as you get deeper. So you could have deeper penetration. So if you have a young patient with really aggressive caries, you're going to get more silver penetration versus sclerotic dentin, like in this, where it's almost tertiary dentin laid down, you're going to get less silver penetration. 2D AI now does the measuring for you. So here's another patient with deep caries, and you can see that mesial pulp horn has not receded. So those tubules are going to be more open. You know you're going to have more penetration with your SDF because that healthy dentin is going to have wider open tubules because there's been no time for that pulp horn to recede and lay tertiary dentin down. So this is what I love about Pearl. It tells me I've got about 0.8 of a millimeter left of, we'll call it remaining dentin thickness. And they say x-rays are 20% off. So I'll bet you I only have a 0.5 millimeter. So you got to be very careful here about drilling deeper and deeper. You're going to want to leave, I believe, some infected dentin for sure, right over that area. And it's been proven over 50 years, it's okay to leave, just seal the area. So here's your infected, here's your affected, and here's your healthy. This is what we have to deal with. This patient's totally asymptomatic. 2 different situations. Get back to Michelle. So I opened up the initial area just to show you. The brown halo, as you can see in the distal pit, I've opened up part of it, but I could see that other part that I haven't opened up. You can see that brown halo. So I'm expecting a deep cavity based on the x-ray and the reading of a 68 on a diagonal. So this asymptomatic lesion on a patient who never had any restorations turned into this. So the question, as you look at this again, this has been telling me that caries has been ongoing and you have a lot of tertiary dentin that's been laid down to be protective, which is good. So back to you, the question, when do you stop drilling? And the answer is not when you see the pulp. She's asymptomatic. You do not want a pulpal exposure here. You absolutely do not want a pulpal exposure. So this is where selective caries comes in. So option one, you look at the x-ray and you're going to assess the area after you've opened it up. And if you're only moderately deep, and I call moderately deep, you're not within 1 to 2 millimeters of the pulp. And I felt I was about 2 millimeters from the pulp. I'm going to remove all the infected dentin. I'm going to remove the majority of the affected dentin, which is a little bit leathery because I'm not close to the pulp. And routinely, I'll use a Cerebur to remove the infected and the leathery affected dentin, again, at 1,000 to 2,000 RPMs. And if there's an area that's a little deeper and you want to just use a smaller Cerebur, just use a smaller Cerebur. This will not take healthy dentin away. You must verify that you've removed all the decay along your axial walls. That's your seal. Option two. So now you're drilling, and now you're thinking, wow, I'm within a millimeter of the pulp. I'm going to tell you, stop drilling. You're not in dental school anymore. The literature supports this. This is selective caries. Stop drilling. Leave that infected or affected dentin. Just leave it. Do not violate the remaining dentin thickness. So I tried to color it this way. This was her lesion. Her lesion is greater than 2 millimeters away. I'm just going to take away all the infected and caries affected dentin. But if her lesion was within a 0.5 millimeter of that pulpal area, I'm going to want to leave some infected dentin. I am going to want to leave it because the literature shows once you violate that 0.5 millimeter, you could be leading to a root canal. So I'm going to tell you, just stop. Just stop. But if I'm going to use SDF, I'm probably going to say I'm going to leave a little bit more leathery dentin and maybe a little bit more infected dentin because I know the SDF is going to permeate. Or if I'm close, the other option is instead of SDF, I'm using a product called Hybenix. Hybenix is sold through dealers. And basically, it's a sulfonated phenol, and it has sulfuric acid. And basically, you create this electrostatic charge when you apply it. I mean, it's not like electrical. And basically, the charge attracts water from the cells. And you just, after you apply it, which I'll show you the technique, I think this is also a must-have in a practice just to remove biofilm and deep caries, like in this situation. So this will remove that bacterial biofilm. So in this case, this is from another dentist. The dentist stopped drilling when he was literally within a 0.5 millimeter of the pulpal tissue in these two areas. And instead of using silver diamine fluoride, he applied Hybenix. And basically, you're just going to apply it for 15 to 30 seconds. And it actually can be used to stop bleeding tissue. And there's many other reasons it's used in perio all the time. You're going to rinse it, blot dry. And I like to leave it mildly moist, just just dry it with a micro brush. And now I'm basically going to place a light cured calcium hydroxide liner, like a Theracal, for example, or a Protect LC or a Limelight. That would be my approach if I'm 0.5 millimeters or less. I'm not going to use SDF. But here's what's amazing, and I had no idea about this. SDF in this study and other studies was shown to be more successful at creating remineralization and tertiary dentin formation than calcium hydroxide. Now think about that. We've all been taught you have a deep lesion, a relatively deep lesion, put calcium hydroxide down as a liner. And I get that. And a lot of people overuse liners. And I'm not sure liners are really much more indicated except for this situation. Because when you're more than a 0.5 millimeter away, I'm going to use SDF routinely to create better dental tooth structure long term, because again, you get better tertiary dentin formation with SDF. So in this case, the caries were moderate in depth, and I didn't approach the pulp. So here are the options for restoring this patient. You could do a bulk fill. You could do a bulk fill with a dual cure or self-cure composite and a capping layer. GC America now makes a bulk fill fiber reinforced composite that you cap with a layering composite. You could rebuild this with 2 millimeters of flowable composites or warm composite, 2 millimeters in increments. Or you could rebuild the dentin with an RMGI and a capping composite. And that's what we did here. So here's the RMGI approach. You could etch, or you can condition. So for me, after I've already done my Silver Diamine Fluoride, I'm just going to then go I'm basically going to condition the dentin for 10 seconds instead of phosphoric etch. I'm just going to rinse, blot dry, and I'm going to place one of my RMGIs. A light curing glass ionomer, 2 millimeters is the recommended depth. In this case, I used Riva Light Cure. It comes in 2 viscosities, has excellent fluoride release up to 6 weeks and beyond, less than a self-cure, but still excellent fluoride release. And here are the clinical steps. You're going to place your RMGI and always leaving your tip in the material. I'm going to wait again 30 seconds. I like to dip my instrument in what I would call a Riva coat. It's kind of a unfilled resin, and I'll just dip my instrument, pack it down after 30 seconds, and then I'll light cure for 20 seconds. That's it. So I wait for a little bit of setting, pack it down, 2 viscosities, re-prep like I did the first restoration, and I'm going to want a final. I want this layer to be 2 millimeters, but I also want my final composite to be 2 millimeters. So sometimes my RMGI could be 1 millimeter, millimeter and a half, whatever. Maximum is recommended is 2 millimeters. I'm going to rebevel all my occlusal walls and etch and bond. Total etch. I'm not worried about dentin etching. Dentin's all covered up. I'm going to rinse, blot dry, suction dry. Apply my bonding agent like I just shared with you. Light cure my resin for probably 20 seconds. I pretty much always minimum do 20 seconds moving my light. You could rebuild the buccal and then the lingual. Again, I do that routinely, just not one layer. You could also put a little flowable down first just to cap the RMGI, just a little flowable, light cure the flowable, and then just put in your final capping layer on the buccal and lingual. So here's your remaining dentin thickness, not an issue. There's your RMGI. There's your composite. And this is the zone of remineralization that SDF brings to the table. That's why I love it. I mean, it's that extra remin. This is what it looked like, and then I placed a sealant over the rest of the grooves. Asymptomatic, and she never was symptomatic after placement. Finally, I just want to close on one of our geriatric patients. This is Jim. He's 91 years old. He's in bad health. He's visiting from Colorado to see his grandkids. Doesn't want x-rays, forget that. Doesn't want crowns, I get that. Doesn't want shots. And he wants a minimal amount of drilling done. Typical of my geriatric older sickly patients with rampant caries. So this clinical trial showed that after 30 months, 64% of the patients with root caries came back. Look at the arrest rate. Okay, this is the arrest rate. 45% arrested just from basically varnishing. 90% with silver diamine fluoride, Riva Star Aqua, which is the water-based, not ammonia-based. Riva Star Aqua, the one I've been showing you, 93% arrested caries. 93%. And the distribution of arrested caries, the lesion, the color was not significantly different between SDF and the SDF with potassium iodide. This is what I had told you. So if you're just not removing any of the infected dentin and you're just putting on SDF with potassium iodide, Riva Star Aqua, you are still going to see a blackening. You are, and that's what this article and this study showed. These are the codes we use. 1354 per tooth. So when you apply silver diamine fluoride, which I'm going to show you, this is the code per tooth. Now, one of the recommendations is to use a fluoride varnish over it. And this is what we do. We're just going to put varnish over all the teeth in general. So that's the code for fluoride varnish. So you can be making good money using this code and then putting varnish over it. You don't have to put varnish over it, but those are the two codes. So here's his x-rays in Pearl. We scan every new patient, my Taro scan at the time. This just shows you all the caries. Caries. These are his x-rays. And you can see he's got early lesions proximally. Some are in deeper enamel. The distal of the bicuspid, the second bicuspid is in deeper, it's in dentin. And obviously he's got incipient lesions that I'm not worried about in the contact zone. So what are your options? You can just apply silver diamine fluoride biannually every time he comes in. And if you want to put varnish over, just do it. And it's one treatment option. Second treatment option is go in there with that Cerebur, take out the caries, just selectively take out the caries. You don't have to remove them all. Just remove the, what I would call soft caries, and then apply silver diamine fluoride. He won't feel it. The third option is you could do selective caries removal, apply SDF, and then place an RMGI right over it. And your RMGI is your final placement. Going to his other side where he was trapping food. Standard x-ray. Now with Pearl. The same three options occur here. But if you want to stop the food impaction and not just place the RMGI laterally on his lower bicuspids, you could then do a traditional class 2 if he would let you, if Jim would let me. And what I would do is then I would just take out the amalgam. The other one was a composite. Just take them out. Do selective caries like I'd shown you today. You can leave caries. Probably do this without any anesthetic. Apply the SDF first after the drilling. And then place your composite or glass ionomer and composite, however you want to do your class 2s. But these are the approaches for everyday dentistry as I look at it. So before I take questions, I just want to say to you, first off, thank you for sharing your night. There are even more multiple ways of incorporating SDF into our practices, but I felt that this was my first go at sharing how to kind of standardize using it for not just desensitizing teeth on label, but for more. So I'm going to open this up now. I'm going to take some questions. And I know it's a lot of information, but let's take some questions and we'll go from there. Did you say you rinse the SDS after etching and applying the dentin before restoring? And the answer is, so after I place the SDF on the tooth, the silver diamine fluoride in step 1, then I place the potassium iodide I will rinse the restoration, yes, before I either use a conditioner or a total etch. I will rinse the silver diamine fluoride. So yes, that's what I will do. If I'm desensitizing a tooth, I do not rinse. So I just want to be clear, desensitizing, I blot dry, but after the SDF, I will rinse, and then I will either recondition or re-etch before I place my glass ionomer or composite as I rebuild the tooth.
So one
Yeah.
of the questions that came up, the first one was, why not use a curette to remove decay?
So first off, you can absolutely use a curette to remove infected caries. There's no doubt about it. My feeling is when I'm using the Comet burr, it's just easier for me to do. It just does what a burr does. If you don't have the Comet burr, you can use a curette. I routinely can use a curette to remove some of the leathery affected dentin. That's up to you. That is totally up to the doctor who asked that. I just find I have uh, better dexterity using these Comet burrs. Also with the curette, you're using a force at 1,000 to 2,000 RPMs. You're just basically just stroking that tooth and you'll see the shavings come off. I just think it's more accurate than just a curette. But a curette you can absolutely use. Adrian, let's go to number 2 question.
Sure thing. So this person said they missed the beginning of the class. Can you explain when the silver diamine is used, or the silver diamine fluoride is used, and how much caries do you normally leave in the tooth?
So again, that's up to each dentist. So as I said to you, if you have a geriatric patient, I would always try to remove the external infected caries as much as you can. I obviously don't want to violate my remaining dentin thickness of at least a 0.5 millimeter, and that's what we were talking about. But on a geriatric patient, you've got, let's say, a Parkinson's patient, and I won't even talk about kids, but if you've got a geriatric patient, you can remove all the soft caries and then apply SDF. And if you want to leave some of the soft caries because you feel you're getting too deep, then just place the SDF then. Just understand the more soft caries you remove, you allow what I would say a little bit more efficacy of the silver diamine fluoride. But the research shows that it will penetrate through the soft caries into the affected dentin and often reach the healthy dentin. It's just more likely if you have just a bolus of infected dentin, get rid of that initial bolus. That would be my answer. Okay, next
Okay.
question.
Next question. Does SDF affect bond strength?
So that's the interesting question. By the way, Adrian's my go-to on this. The studies are very variable. And I know Robert, you asked this. Well, it was Tom who asked this question. There are studies that say it does affect bond strength, and there are studies that say it doesn't. So I will just tell you that we have done bonded restorations to silver diamine fluoride, treated dentin, and we have obviously used glass ionomer. And the literature goes both ways, but there's absolute literature says that this does not decrease bond strength. For me personally, if you've got silver in there and it's obviously remineralizing and plugging up those dentinal tubules, common sense would make me think that bond strengths could be affected, but the literature goes both ways, and there is solid literature say to bond to it. Adrian, would you want to comment on that?
No, look, I think you pretty much got it. The literature doesn't say one way or the other, whether it increases or decreases bond strength. One thing we do know, if you do apply SDF, if you then apply glass ionomer on top, you will get a better bond strength with glass ionomer. There's some research behind that. It's Dr. Jeff Knight, and you could probably find that online.
Caries under crowns is another question. Will tell you, Robert, that is very typical in my practice. So what I routinely will do is if I feel the caries, I'll go in and I'll remove the infected dentin. And if the infected dentin is going underneath the crown, I will ask the patient for permission that I would like to drill some of the crown away, the margin of the crown, and maybe a little bit more, so I can have access to remove more of my infected dentin, place the SDF, and routinely repair it with an RMGI. So that would be how I would go approaching repairing crowns. If it's just along the margin, then you can just take a small burr, remove the infected dentin, and then just apply SDF every 6 months. And every 6 months, you're going to minimize recurrent decay. So again, if there's a large hole there, I'm going to want to plug it. And routinely, I'm going to plug it with an RMGI after silver diamine fluoride. Other questions?
Yeah, so another one here is, I noticed that when using SDF KI, when I light cure a resin after GI, the staining appears worse. Do you know why?
Yeah, so the light can actually pull the silver ions up. And so light curing actually can affect your blackening around the margins. And that has also been documented. So again, it's all based on depth. So as I place my potassium iodide and make sure it's clear, I prefer to place an RMGI down. But if you want to place a solid glass ionomer over it, I personally have seen less black coming up because I have that barrier of self-cured glass ionomer, not resin modified glass ionomer. Adrian, your thoughts on that?
Yeah, most definitely. The recommendation would be to use glass ionomer and then a sandwich technique to avoid any staining from the light pulling out the silver. So yeah, that's all I can add further to that.
So I don't want to confuse everybody. When you use a regular glass ionomer like the Riva self-cure, it is not light cured. So there is no light activating and pulling up, is my feeling. You also get a little bit more enhanced fluoride, but you get less compressive strength. I've been using self-cure glass ionomer for decades. There are speakers who say you shouldn't use it. I've been using it for decades, and I'm giving my age away. And I have seen great support when I've removed old composites or old crowns that I've rebuilt with glass ionomer. I don't see recurrent decay. So I like to use the RMGI as my outer layer. So let's say when Robert asked about repairing a crown, I don't like to repair a crown with a regular glass ionomer because it doesn't have enough strength. So I'll use the silver diamine fluoride, and then I'll cover the external surface with an RMGI. That's my approach. A regular glass ionomer, I just find that from toothbrushing and acidic attacks, it can wear away externally. So that's my thought on that.
So the next question there's a couple more. I'm currently using SDF from Elevate.
Yeah.
Directions are to do a second application in 2 weeks, then wait 3 or more days to restore to prevent leaching of the SDF. Do you recommend a second application of Riva and then every 6 months if you are not restoring the tooth?
The literature on Riva, for me personally, showed that if the patient was coming in every 6 months, you could arrest 93% of the caries. That's my intention. I think Advantage Arrest and by Elevate is a great product. And for me to then bring a patient back in 2 weeks for that visit, I would follow their protocol. I don't think there'd be any contradiction to doing it with Riva Aqua either. But openly, I just routinely with my geriatric patients, I just bring them back every 6 months and reapply. And I'll just ask Adrian, is there an indication that you've seen with better results bringing them back in 2 weeks?
No, probably the only thing I can add to that would be if you've got a patient that's heavily compromised, that has a significant amount of caries for whatever reason, then it probably would be prudent to bring them in a bit earlier and just check that the lesion is being arrested. There's no harm in applying
No.
a second amount. So again, I think it would be patient dependent and situation dependent. And certainly, as you said, the literature shows after that a 6-month checkup is adequate on the majority of patients, I would say.
And without a doubt.
Yeah.
Okay, I know there's more questions and I know we're running a little over, but let me just answer a few more, Adrian, if you don't mind.
Yeah, sure. So if caries can be completely removed and still have a safe thickness of dentin, is it best to remove the caries completely and lay a composite restorative?
So my feeling is I would want to remove, if I'm more than a millimeter away for sure of the pulpal chamber, I have no problem removing all the infected dentin and caries affected dentin. If I've got solid tooth and a solid remaining dentin thickness, usually at 2 millimeters, I'm not concerned because the literature started at 2 millimeters remaining dentin thickness, then went to 1, then 0.5. So my feeling is if you've got a cavity, class 1, class 2, that's 2, 3 millimeters down, take out all the infected, take out all the affected. Well, once you're down 5, 6, or 7 millimeters, the literature supports removing all the caries on your walls, and you can leave caries on the floor. And that caries on the floor is best treated with silver diamine fluoride, no doubt about it, because it will penetrate all 3 layers, the infected, affected, and get to healthy. And that's what I love about this product. But no, on a early caries or like early moderate, take out all the infected and affected dentin for sure. Adrian?
Hey, there's a part 2 to that one. Also, once the caries is removed, do you recommend using GI routinely in a sandwich technique or just use composite? I think you answered it, but did you want to add anything further to that question?
So I'm going to tell you this. This is the real world of dentistry. GPOs dominate. I won't get political. You're paid X amount of dollars, and speed is everything. But what I can tell you is that after doing direct restorative dentistry for 35 years, I have gone into countless broken down composite restorations that I placed glass ionomer, and you don't see the caries penetrating down the walls of the glass ionomer. If you were working on me and I had a 5 millimeter depth lesion, I would love it to have a glass ionomer base. This is how I feel. And then a final capping layer. But that's me. If there's a crack, a visible crack that you're more concerned about, then openly I may use a product that has fiber reinforcements in the flowable to minimize the crack propagation. So each tooth presents a little bit differently. But I happen to like a 2-stage closed sandwich technique with a glass ionomer and a composite over it. I've loved it for years. But again, that should be beyond 3 millimeters in depth. Otherwise, it's a flowable and a capping layer if it's 3 millimeters or less. Okay, next question.
Yeah, one more here. Oh, no, there's another one that's been added. But what is your favorite brand of glass ionomer?
So puts me a little on the spot. I've had great success with both GCs and SDIs. I think it's a bit of feel and the way you want to do it. Now, openly, if you're an RMGI and you don't have a triturator, SDI really doesn't have that answer to you yet, because GC America has like a dual barrel syringe RMGI delivery system for an RMGI. But if you have a triturator and you like the packability, which I happen to love, and having the option of a fast set, I love that. I think both companies make great glass ionomers, and that would be my political answer. Okay. The question by Dawn is, can an assistant place FCF? This is what's really interesting, Dawn. Hygienists, state by state can be determined whether a hygienist can place SDF over a caries lesion. The dentist walks in, diagnoses, hygienist can. It depends on the state. I would say state by state, it depends on whether an assistant can. I don't know. I would believe EFTAs can. Whether you're in a non-EFTA state, you'd have to check the law, whether an assistant can place SDF. That would be my answer, Dawn, to you. Okay.
Okay, there's a
I,
couple
yes,
of Q&A.
great.
Do you want to keep going, Lou?
I just love the fact that everybody's so into this because I think it's a great opportunity to share. Go ahead. Thank you.
Okay, I have had an issue with small shallow composites causing post-op sensitivity. Can you comment on why this may be happening?
Yes. So what's really interesting, that is a total C factor opportunity there. So even if you're etching normally, and I'm just going to say this to everybody out there, you etch for 15 seconds. I don't care whether you're total etch or selective etch, because I've been a total etcher forever. If you total etch and you place your bonding agent in and you scrub it in for 20 seconds, follow the directions, and now you're about to air dry. So you're going to etch, you're going to rinse, blot, dry, not air dry, rinse and blot dry. Now you're going to place your bonding agent. When I'm air drying my bonding agent, I'm telling you this, you want an air only syringe, not an air water. Water, I know you squirt the water out of the air, but there's still water droplets. The water creates a hydrophilic moment, and all of a sudden your hydrophobic bonding agent isn't so hydrophobic, it starts leaking. If you're doing everything right and you're placing your composite and you're having sensitivity, it's probably honestly then a little bit of what's happening before you're placing your composite, the way you're etching and bonding. I'm going to just tell you, and you may not like this answer, if I have a small class 1 and it's not in any occlusion, all my children that I have restored, and I can't tell you hundreds to over 1,000 patients, I put a glass ionomer in a small class 1s. You get the remineralization effect, then you just put a coating layer. SDI makes Revacoat, and GC America has their Equiacoat. But if you think about it, you have a small class 1. Why not place just a glass ionomer, just pack it in. It's not an occlusion, and you'll see it last decades without any brown marginization occurring. Long answer to your small class 1 question. Anything else, Adrian?
Yeah, there's another one here regarding subgingival cavities. Would
Yes.
you recommend open sandwich technique over a closed in that sort of a situation where there is subgingival cavity?
No. You're going to have to another course. I do a raised, I elevate my margin. So I've learned this. I will tell you if I'm doing a class 2 and I put a RMGI on the bottom of it, I am just long-term concerned about getting my class 2 packed material down with absolutely a perfect margin. And then what happens is your hygienist is in there a year later with an open sandwich. She's using her ultrasonics, and now she's scoring your RMGI in the bottom of the box. So I would do an elevated margin technique. And honestly, for anybody out there, you can email me at lou@catapulteducation.com or request it from Lisa, and I'll send you my elevated margin technique. I use RMGIs on class 5s, and I use it to repair crowns externally, but I don't really love the open sandwich technique. Somebody asked what brand of an air syringe. Just call Shine, Benko, or Patterson and let them put in an air syringe. It's less than $200. They're in every restorative room we use. Like using nitrogen instead of an air-only syringe. I have no issue with that either. Do you use a desensitized like Gluma or G5 for your restorations? I know it's going to sound terrible. I haven't used Gluma in decades. I believe you can properly etch and bond without it, but I'm not anti-Gluma at all. I'm not anti it at all. Okay. Adrian, I have to cut it because we're so past the hour. And if any of you have more questions, just email and I actually will follow up with you within a few days. I absolutely promise. And thank you all. This has been a huge crowd tonight.